Hello, my name is Dr. Ragheshri Dharawan and I'm an HIV doctor at Barts Health NHS Trust in London. Thank you very much for the opportunity to present today. So we know that epidemics can exacerbate disparities, but disparities can also exacerbate epidemics. So when we think of HIV, while we're making great progress globally, there are groups that do face disparities and some groups are not doing as well as others. So if we take a look globally in 2019, we know that 1.7 million people newly acquired HIV, and these were mainly people from key populations and their partners who are at higher risk of exposure to HIV, and they account for 62% of new infections globally. These key populations include transgender people, men who have sex with men, sex workers, and people who inject drugs. We also know that adolescent girls and young women in sub-Saharan Africa are 3 times more likely to acquire HIV than their male peers. And there's also disparities in access to antiretroviral therapy, with 12 million people not having access in 2019. And we know then that 700,000 people died of AIDS-related conditions, and children are more likely to be affected, with less antiretroviral coverage and a greater proportion of AIDS-related deaths. And disparities not only exist between countries, they can also exist within countries. So using the UK as an example, this is a country that has met the 1990 UN AIDS targets and also has universal health care with a national health system, but there are still considerable disparities, particularly by ethnic group. So some research that we did looking at clinical outcomes amongst heterosexuals in the UK by ethnicity found that people from racially minoritized groups were more likely to present with low CD4 counts, more likely to experience viral rebound, and less likely to spend time engaged in care. We know that they're more affected by HIV, with 74% of heterosexual people receiving HIV care in the UK from ethnic minority communities. And whilst new diagnoses are going down amongst men who have sex in men, this is mainly in white men who have sex in men. So moving on to COVID. So this is a photo of the National COVID Memorial Wall in London, and this sits on the River Thames and it's opposite the Houses of Parliament where the government sits. And on it, we have 150,000 hearts painted to represent each of the individuals that have died from the pandemic so far. And we certainly know that COVID has affected different groups differently. The Scottish writer Damien Barr has eloquently written, "We're in the same storm, but not in the same boat. Some people are on super yachts and some just have the one oar." So for example, in England and Wales, we know that people living in the most deprived areas are twice as likely to die from COVID-19. They have an increased risk of exposure and increased risk of poor outcomes. There are people in precarious, low-paid manual jobs in the caring, retail and service sectors who are less able to work from home. They live in overcrowded, poor quality housing in densely populated areas. They're also more likely to have higher levels of pre-existing illness and poorer access to healthcare. And even before COVID, life expectancy was stalling in many of these areas, particularly for women. And this is on a background of 10 years of austerity, particularly in the most deprived areas, leading to increasing food insecurity, child poverty and homelessness. And all these have affected health outcomes and life expectancy. So health inequalities are best understood in the context of the social determinants of health. And this is something that has been known about for a long time. And for example, renowned sociologist and civil rights activist W.E.B. Du Bois was amongst the first to note that health disparities of Black people compared to white people in the United States stem from social conditions due to racism rather than inherent racial traits. And let's just remind ourselves what the social determinants of health are. So from the World Health Organization, they define them as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, developmental agencies, social norms, social policies and political systems. And I've listed some of the determinants they mention. In essence, we know that most people's health is determined before they reach the clinic door. And I think this photo illustrates the social determinants of health very well. So we do know that obesity is a cause of cancer, but what can cause obesity? And I think this graffiti artist has illustrated this very well. So naming some of those causes, which are social determinants, being poverty, inequality, and austerity, essentially the causes behind the causes. But what are the causes behind the causes behind the causes? So at the root of the social determinants of health is an inequality in power. Where we stand in the social hierarchy affects our chances of good health. And those causes behind the causes behind the causes are types of oppression, including, for example, structural racism, gender inequity, homophobia, and transphobia. And it's important to take an intersectional approach, realizing that many people may face one or more of these oppressions. And for me, one of the things that has given me great hope over the last few years is seeing the progressive movements against these oppressions. So, for example, the Black Lives Matter movement, the Pride movements, and the Me Too movements. So what impact has COVID had on the social determinants of health? Well, Oxfam have compiled some stats as part of their report, The Inequality Virus, and they showed that some people did well out of the pandemic and some people have not done so well. So between March to December 2020, billionaires increased their wealth by $3.9 trillion, with a total wealth now of $11.95 trillion. And this increase in the 10 richest billionaires' wealth is enough to pay for COVID-19 vaccines for everyone and to prevent anyone falling into poverty because of the virus. And who's not doing well? Well, the majority of people. COVID-19 has pushed 119 billion people into poverty in 2020, with women overrepresented in the economic sectors most hit by the pandemic, putting 112 million women at high risk of losing their jobs. We know that 1 billion children miss schooling, and rates of intimate partner violence have increased. So what can we do about these inequalities? So we need political will, and we need governments to take actions to tackle inequality. Governments need to focus on inequality and set goals to address it. They need to turn from austerity to progressive policies such as a universal healthcare, education, social care, and other public services, and consider universal basic income. They need to ensure employment rights such as living wages, sick pay, paid parental and carers leave, and unemployment benefits. And they need to consider progressive taxation of the wealthiest corporations and individuals. They also need to address climate change so that we can have a green economy for the next generations. Essentially, we need to work together to rebuild our society, our systems and our institutions, to be more accountable, to prioritise the social contract over the economy, and to be more inclusive. And there's lots that we can learn from the HIV response. So we know, for example, that addressing social inequality is vital. We need to use a human rights-based approach as this is most effective, and that communities most affected by disparities must be at the centre of every response and must lead the response. We need to have more collaboration between health and non-health organisations, and we must challenge exclusion, so thinking those oppressions I described before, such as structural racism. We must also ensure equitable access to new health technology. And I think we also need to think about how we teach about the social determinants of health. So I remember for me at medical school 20 years ago, when we were taught about it, we were concentrating on the things that we thought could be changed. So behaviours, for example, there was an emphasis on individual lifestyle factors, encouraging personal responsibility and lifestyle modification. And so essentially we were encouraged to tell people to stop smoking, to drink less and to exercise more. And whilst these are really important, it does place the onus for poor health on the individual, rather than looking at the rest of the social determinants, which may be affecting their ability to carry out healthy behaviours. And I think this is a form of victim blaming. It's blaming the individual, the minoritized group, for the problem, instead of societal structures and processes causing the disparities. And perhaps that's because it's easier for us to concentrate on what we think can be changed, like behaviours, rather than the wider determinants of health, which are harder to change and may be out of our power. In this paper, Sharma et al. Have addressed this, calling for a change in how the social determinants of health are taught. They should be taught as not facts to be known, but conditions to be challenged, and that they are not natural or unchangeable. They feel we should focus on the root causes of health disparities and take a structural competency approach to our patients, so thinking about the systems that affect them outside of clinic. So in conclusion, we cannot just rely on the biomedical response to epidemics. The disparities we see are driven by the social determinants of health are not differences in culture or innate biological difference. They're due to the social determinants of health. COVID has further exposed and exacerbated health inequalities. So how can we protect the gains made in HIV? And can we use the political will and momentum to address HIV? And finally, a question for all of you. What can we do ourselves to better advocate for those at the margins of society? So thank you very much for listening, and I look forward to the Q&A.